Ladies and gentlemen, welcome to this week's edition of What the Health Just Happened, where we talk about all things healthcare, the good, the bad, the ups, the downs, the lefts, the rights, and everything in between. We also bring on a variety of business and community leaders to discuss healthy versus unhealthy business and life practices. And today's guest, I imagine, will be a healthy dose of healthcare and business and life. We have two representatives of Cardiac Vision, John Moses, Regional Director of Marketing for Cardiac Vision, and has a plethora of experience in the healthcare world and hospice, home health, both pediatrics and adults, right? Mm-hmm. Okay. We also have Dr. Carlos Zamora. Did I say that correctly?
That's right.
I do not like butchering names, but it happens all the time. A board-certified cardiologist with Cardiac Vision and an assistant professor with the University of Florida, amongst many other impressive accomplishments. Oh my gosh, the intro is always the hardest part. Do you read? Do you go off the head, the dome? I don't know how you say that. What do the kids say off the dome? Doesn't matter. Gentlemen, welcome to What the Health Just Happened. A lot of stuff to cover, right? I assume we'll do a little bit of business, a little bit of healthcare. Who wants to take the first swing?
John brought me here, so he's
going first.
I know. I convinced Carlos at the last minute. Dr. Zamora, get over here. Come on, come with me.
I'll throw you an easy softball to start. So John
good.
and I have known each other for a while. You're in the healthcare space. You've done a variety of things. What is Cardiac Vision, right? What do you do? Who do you service? And where do you service these patients or clients, whatever term you use?
I mean, it sounds like you want the elevator pitch.
Give me the elevator pitch.
We're going to get the timer.
Man.
I got the timer up there.
I'm going to hit floor 30
seconds here. Here we go.
Excuse me. You got 24 minutes till the commercial break.
Exactly. So Cardiac Vision, we are a post-acute specialty group that only rounds inside the post-acute. And what the post-acute is the skilled nursing facilities, like nursing homes, and the assisted living facilities, which is an ALF, or the inpatient rehab hospitals. We don't have an outside clinic. We're not rounding inside we don't have a clinic that we're trying to send patients to and see them inside of an office. So we round inside the buildings. And so by doing that, we're able to work with patients from long-term care to short-term care to either sometimes a 14-day stay in out. And then we see those patients through that entire post-acute continuum until they get discharged. And then we hope to have them discharged to a place that's going to be successful upon that, either working with a brick and mortar cardiologist, get them with from a telehealth standpoint, whatever it may be, to get them to lead them to success so they can stay out of the hospital pretty much. And that's the very, very short version of what we do.
We'll dive deeper. Anything you want to add to the elevator pitch?
I think it serves a need that is now talked about in main healthcare type of stream. Everybody talk about the clinic, about going to the diagnostic center or a hospital, and this is an area that is very important because most issues and most mistakes, let's say in medical training or in the hospital, happen between transition of shifts, right? When you have handoffs between residents, between nurses,
shift change, leaving the hospital
and
to
that probably and that might be the same in security guards or some many other industries, but especially in the healthcare, that's where the most dedicated point that, like any chain, like you can break the link, and that's really what the Cardiac Vision team is doing, is getting after the hospital, taking care of those patients throughout the discharge and post-discharge, rehab and post-rehab. So those are usually the weakest link because health systems and many hospitals do a great job in-house, and then after that, right, what happens? So this is a filling in a need that is very important.
Much needed niche. I'm going to read this because I pulled it from your website. Cardiac Vision combined with Cardiorenal Therapeutics, CRT, is a physician-owned and nationally led multi-specialty practice focused on delivering highly specialized care to post-acute facilities. Right. So unless you want to talk about the renal care, right, the renal therapeutics, which is kidney stuff for all you layman's terms.
Man, don't ask me to explain nephrology because I still don't understand it.
Again, we can stick with the cardiac side because you're a cardiologist, correct? Which I want to talk about that too. Your training where you went to school.
Can definitely
you're gonna put them through the ringer too. You're gonna ask a bunch of questions.
I do want to. That might have to be the second time you come on. Is just talking, just geek out on cardiology.
Right. And what I wanted to add to,
please do.
Eric, is that here you look at a patient's continuum. The day they get admitted to a hospital,
Let's start. How did they get admitted?
So it could be for any given reason. Let's say that they're, they were in a car accident, or let's say they fell, or maybe they had CHF exacerbation, or maybe they
congestive
had
heart failure.
Thank you very much. So they had some kind of clinical need to go to the hospital.
A very common one would be, let's say, an elderly person that is at home and just simple slip and fall and just broke their hip.
It could have been, the hospital looks into the reason why that patient fell. That's a good example where why did they fall? Did they fall because of disorientation, because of low blood pressure, because of mismanagement of medications? Like, what's the real reason why that patient fell? They may have had a hip fracture, and maybe that's one they're going to do an ortho, they're doing surgery, or maybe they're doing rehab. But, what's the root cause of that? And then when the hospital figures out that there is a specialty need like cardiology, maybe there's something going on where they need additional cardiac care. When a patient goes to the hospital, it's like I say this all the time, it's like the Disneyland of healthcare. They go there, they get worked up, they get
everything. Every roller coaster, they have every snack.
All free, fast pass through the whole thing, everything you need to do.
That's a good metaphor.
And they get the Disneyland of healthcare and they go to the hospital. Well, then what happens is, and this is kind of how we got started 10 years ago, is that once they get discharged out of the hospital, they go to the post-acute, to the skilled nursing rehab facility. Usually, up until recently, you're only going to have a primary care. That's it. That's really all. That's all you're going to have in that post-acute up until recently, where you just have a primary care who's managing that rehab, who's managing that patient, and that's it. It's usually one physician or some mid-levels, so nurse practitioners, and it's working. And there's some success there for sure. But what there needs to be, and what we have the ability to do, and what healthcare has the ability to do, is add more specialty groups to that building, and having cardiology overseeing that patient if they do have a cardiac need. And so working with that patient to help work with them from the rehab standpoint, and work with their medications, do EKGs and echocardiograms, ultrasounds, and get that person as much healthcare as possible, much help as possible. So that way, when they get to the discharge point and they get discharged, they're set up for success way further along than they would if they just had just a primary care seeing. And that's where we've seen success, is seeing patients who come out of the skilled and they've had primary care, they've had cardiology, they've had nephrology, they've had pulmonology, derm, podiatry. These things are coming into the post-acute market, which have never been there before. A lot of times when that patient needs something, what they do, they put them in a stretcher, they put them in an ambulance, they ship them out to a brick and mortar specialist. And that worked for years because nobody wanted to come into the skilled. Now, with these entities like us for coming in for multi-specialty, that's where those patients are going to see a lot more workup, a lot more set up for success when they're discharged. So that way, when they go back to a brick and mortar cardiologist or brick and mortar specialist, they have the workup of what's been going on through the entire continuum of acute and post-acute care. I mean, do you want to add anything else?
I'll get a specific question for you and then go back to
go ahead.
Defining post-acute. So I asked before you walked up here, Dr. Z, Dr. Zamora, what should I call you? Dr. Carlos Zamora, there's a lot of names here, right? Right. What do you prefer?
Dr. Z is fine.
I like Dr. Z. That's fun. So as the clinician in this process, kind of elaborate on that. So patient comes out of hospital and they're in a skilled nursing facility. What are you doing with cardiac vision specifically? You're going in as the cardiologist for that patient to get them home and safe, to decrease readmissions? Like, what's the clinician's role in this?
Yeah, it's a great question, and it goes back to how come I ended up meeting them and working together. Was that about a year and a half, 2 years ago, my wife and I actually opened an ALF, assisted living facility.
Okay.
But for 10 years, for 10 years as a cardiologist, I will always see those patients coming into the hospital or the clinic, and I always I had quite a lot of questions, like, why are they on this medication? Why this is not being done? Why is that being done? Why are they here? Why are they not here when they're supposed to be here? All those questions, but I never worked on that side. I was always on the hospital or clinic side. And was only really when we opened the ALF that the mission was to really provide great care, to combine, my wife expertise in business and mine in healthcare, to deliver great quality and great care.
To keep them, I'm guessing,
to keep it safe. Exactly, right? Home and safe. But then when you, like anything else that you do, when you really are doing it day to day, you really start finding gaps and issues and answer to those questions. And so that's when I called, Dr. Ahmed, and I was like, hey, I heard you doing this post-acute care. And I'm learning a lot about it just by taking care of our own residents. So that's how it came from the need of stepping up the care there. So really, when we go in, we are assuming the cardiac care for those patients because, again, most systems don't have the bandwidth to send cardiologists to those locations, to those facilities typically. So if they don't have anybody that is coming in, then yes, we would take care of finding out their records from the hospital.
How easy is that?
It's never easy.
It's a nightmare.
That's like a 10 episodes of podcast
that's
about,
its own show,
about interoperability and things
siloed.
Everything is siloed, unfortunately. We're working towards more interoperability, better communication, flow of records and all of that. But essentially then we assume care for maintaining really what had been done or started in the hospital, because they might have been for a broken hip, but they do have comorbidities, right? We have an older population. We have people, thankfully, are living longer, but what happens when you live longer, you have more comorbidities that you're dealing with, more medications. So they might not be there on the rehab site for a cardiac reason that they came from the hospital, but they do carry several common diagnoses.
Hypertension for years.
Hypertension is at least a third of the population, right? Yep. High cholesterol, another third. Diabetes, about the same rate. Congestive heart failure that you mentioned, all of those comorbidities are very common and also actually multiple of them in the same patient. So that requires making sure the polypharmacy is not excessive. So we're cutting down medications that are maybe duplicate, that may be causing trouble. Let's say they're on double dose of diuretics because they had one from home, one from the hospital, and now they continue both. Now they're dizzy, they're lightheaded, they're complaining they're going to the bathroom all the time. That can even hurt the kidneys or eventually. So those are the things that we line up to get rid of the ones that they don't need, line it all up. So when they end up going home, they have a very good list of medications. They are stable and they're ready to transition back to home or to their ALF. If they are going to an ALF that we care for them, they will continue there. And if they are going home, then we have started actually transitioning with telehealth service to make sure that once they leave the post-acute facility, we follow up with them, because it's not just a question of, hey, you're stable, see you.
Yeah. Thanks for coming.
Yeah. That's not value-based healthcare. That is I was reading, medicine 1.0, 2.0, and now medicine 3.0 is really what we should be doing.
Who are you reading, by the way? I have to ask.
I followed for a long time Dr. Peter Attia.
I love Dr. Attia.
Yeah.
That's what I was going to say. Are you going the direction I think you're going? Have you read his recent book?
I haven't read the book. I have to. But I have followed the podcast
I'm getting off topic. Sorry.
Yeah. No, it's fine.
I have followed the podcast for a long time because I always liked prevention and this type of, medicine 3.0 type of care. And plus I'm from Brazil and he follows Ayrton Senna, which is a Formula One racer. So that's how how it got started. When a friend of mine say, hey, this guy has a podcast.
His is the best out there, by the way. But, it's long form content.
It's long form, but they go really deep into the science. But going back to the follow-up is that's a concept, that is not just one episodic thing. The more data points, and that's medicine 3.0, the more data points that are specific to that person, to that patient, the better the outcome. And that's proven. I always felt for many years in the healthcare system, frustrated really that we see patients every 6 months, once a year, and they come in, you check your blood pressure, as a cardiologist, do an EKG, maybe do a blood work, and you make a decision in 20 minutes about
the next 6 months,
the next 6 months or the next year, or really is when you think about it, is for their whole life. Mm-hmm. Because whatever you do there, starting a therapy or stopping a therapy or recommending something will change the next few decades. So I always felt that you needed more data points. So the more hands-on, the more I like high touch, high tech. The more we can combine
high
that.
Touch, high tech, I like that.
Yeah, I like that because you cannot do it also all manually. You need technology to help you when it makes sense.
And there's so much technology available now. It's kind of, we talk about telehealth, we talk about skill. Like we can do so much more on site with these patients that they couldn't get 10 years ago. They couldn't get 5 years ago. There's just so much more availability for what we're doing. And then I want to kind of add what you said too. And for kind of what we're talking about here from from the skilled side. One of the things too that you noticed, it was a recent patient. I'll give you an example.
I love specific examples.
We had an example where Dr. Zamora was consulted on a patient in a skilled building, and they said Dr. Zamora, his I don't know if you remember this. His blood pressure's all over the place. It's high, it's low. I don't know what's going on. Like, I think it's a cardiac issue. He went in, he did a consult and realized very quickly it wasn't a cardiac issue. It was an infection. And so he was able to rule out cardiac and say, listen, these are all the signs for an infection. Like, this is what's going on.
Was this in the hospital, skilled nursing?
In the
Where was the
post-acute.
location?
In post-acute and acute.
Okay.
Do you remember what I'm talking about?
Yeah.
Is that, yeah.
Yeah, it's that's why you need more touch points. And also technology like wearables or sensors that will alert you earlier, right? The earlier you know, the better. The more continuous measurements that you have, the better decisions you make. People are complex, right? Like I just mentioned, we have a population with many comorbidities, which comorbidities mean diagnoses, really.
Multiple
diagnoses that interact with each other, medications interact with each other. So, and it's not easy. I mean, we don't talk about it, but it's not easy to navigate that. It's not even for patients, not even for nurses and doctors either, because medication is helping one diagnosis, but has a side effect affecting another organ system. Everything's connected. So it's important to take the time to digest that and sort through that. In the hospital, in the acute setting, they have to.
Let me just clearly define quickly acute versus post-acute, right? So acute, you have a sudden issue, you call 911, you take an ambulance there, or you have that fall, or you have chest pain. This landscape of healthcare, right, where it starts, you may have an acute issue that brings you to that hospital setting.
Right. Yeah.
Then you're treated there, whether you go in the ER directly to a floor, they treat you, however long that takes, then you're discharged to wherever. Post-acute setting.
Yeah.
It can be home health care, a lot of times skilled nursing,
outpatient therapy,
to assisted
ALF,
living.
it just
Correct.
depends.
So just understanding that
no, thanks for that's explaining. Yeah, that's a good explanation. I say these terms all day.
And sometimes the same thing. It's like, how do we? I don't know who's listening. I do, but you don't know who knows what acute versus post-acute means.
Right.
Yeah, and even us we're not trained for these things in medical school or residency.
Go into that.
We're not that familiar with it unless you get involved with it. So it's important to explain to anybody. Like if maybe even medical school doesn't teach, I'm sure they don't teach
That's another great point too. Is what you learn and are taught in medical school versus the real world. That's any industry, right?
Right.
Yeah.
It's probably not talked about that much, the post-acute world.
No.
I think it's like understanding the disease process, the medications, how the body works, how to treat something.
Yeah,
Going back to Med 3.0, it's all prevention.
Yeah, it's
that's
all
a heavy
prevention.
emphasis on it.
And that's a lot of what we do is about prevention. It's and I kind of I talked earlier about the primary care and nothing. I didn't want to come off as saying the primary care can't do it, because that's not the case. Because our primary care is they're there to oversee the entire body and the waste. But the kind of analogy I use is that you have a contractor who builds a house. You have a primary care who takes care of the body. When a contractor wants to build a house, what does he do when he wants to put a roof on? Does he put it on himself?
He outsources.
He calls a roofer.
I need a window guy.
You need a plumber. You need an electrician. You outsource it. Those are the specialties you do to build the house. And that's what primary care does. They bring in specialties to do different parts of the body that hyper-focus on the rest of those parts of the body. And that way, not just from hey, here's the heart, take care of the heart, I'll take care of everything else. It's not that. It's saying, let's collaborate. What are you seeing on this heart? How it's going to affect the rest of the body? How it's going to affect the rest of what I'm doing, what we are doing together. And I think that that's so important, especially in this day and age, is that healthcare, it needs to be more collaborative. You talk about silos. You talk about, the hospital does this and they discharge out. And that's, in some markets, that's true. But some hospitals have really good, they're trying to bridge that silo effect and connect with those post-acute abilities, those ALFs, those home health, the outpatient clinics and stuff like that. And there's a big need for it. And they're seeing the need and the conversation to happen.
So 2 questions. One, I wrote down a list of people. This is locally here in Northeast Florida, Jacksonville, Price, St. Johns County, the Big Five, Baker, Clay, et cetera. You're working with, what were the hospitals you guys are currently working with? I got it. Memorial, UF Health, Baptist, Brooks Rehab, St. Vincent's. Am I missing any big ones?
I think that's all, and Orange Park and HCA. So HCA, which is Orange Park Memorial.
Yep.
St. Vincent's, which has 4 hospitals. Baptist has 4 hospitals. Mayo Clinic and UF Health. And then Flagler, UF Health Flagler. So that's just those 5 markets you mentioned. We cover from Jacksonville all the way down 95 through Daytona. which includes Halifax and Advent.
Yep.
Then you have all of I-4, which is from Altamont Springs, Deland, Deltona to Orlando, which is Orlando Health and their hospitals.
people.
And those, yeah, exactly. And then through Lakeland, and then all of Tampa Bay, which goes far north as Wesley Chapel, Spring Hill, Newport Richey, all the way through St. Pete, Clearwater, and then all the way down through Sarasota, Bradenton, and we're expanding from there. And that's not including Chicago, Dallas, Seattle, Kansas City, and Madison, Wisconsin. Yeah, exactly.
All right, I'm gonna plug.
I
this
gave you a lot
event.
there. I'm sorry.
No, this is great. I told you the time's gonna fly by.
Yeah.
And I know I'm watching the clock. We've only got a couple minutes till the commercial break, but we're gonna talk about this event a few times. So this is, I don't even know what day it is today, but
It is the 4th.
so Florida's 5th annual Post-Acute Care Symposium. There's some big names on here, including Dr. Z. I'm gonna start calling you that. Let's see, October 13th from 9 a.m. to 3 p.m. at Deerwood Castle.
Next Friday.
So say the date again, say the time, look into that camera if you want. Anything you want, we'll chop it up and send it to everybody.
It's all good. It's October 13th, 2023. It's at Deerwood Castle. It's a post-acute symposium. Basically, we're going to have the local hospitals are all the ones that you mentioned. We're going to have physician groups, specialist groups, skilled nursing, ALF, home health, hospice, palliative, third-party therapy, and then everything else in between. You know, everybody who's a healthcare professional, healthcare clinician, if they want to come and join and come, kind of revel in the spotlight of this post-acute collaboration is what it is. And it's grown every year since we've done it. And this year I'm expecting it to be quite the thing. I hope you're coming.
I plan on it.
You
Yeah.
better come. I mean,
I'll be there.
You don't have
I'll
a choice.
be there. I'll
come
be
for
there.
an hour. Come
I'll
for an
be
hour.
there.
Okay,
Come
I don't believe him. Well,
I will 100%.
Tune in next week.
I
to
will
see if he shows
100%
up.
be there.
No, I like how it changed.
Listen.
I may come. Yeah, I may come.
No. I'll be there. The only reason I'm like, am I in town next week? I am. It's in my calendar. I blocked the whole day off.
I don't believe it.
Oh,
He'll text me
stop.
morning. What day is that? Second?
What are you talking about, Dr. Z, at this specific? Do you have a segment you're talking about?
Yes,
Or you're just
my interest is in telemedicine, remote patient monitoring.
oh, boy.
You
Whole
know,
different episode. Here we go.
Yeah.
Sorry, go ahead.
Yeah, so that's what I'm going to be talking about, the initiative that I'm helping build out for bridging that gap now.
This is specifically in the post-acute
Yeah.
world.
Yep.
We might have to hit that on the second half. Just maybe some introduction, some other people in the telemedicine space here you may be familiar with.
Yeah.
But that's a
Yeah.
whole different topic, right?
We're going
Let's
to talk
see.
about. We're basically going to talk about a lot about the relationship between the acute hospital and the post-acute skilled and ALF, and basically, really honestly discuss and try and figure out a collaborative understanding between these entities, between these companies. You have Baptist just focusing on Baptist. Well, Baptist doesn't want to just focus on Baptist. They want to work with strategic partners who are going to get the most bang out of their buck for those patients, to get them as healthy as possible, and not either work to go to the skilled or just to go directly
Let's
home.
acknowledge, let's call it what it is too, to decrease readmissions.
That's the end of
right?
the day.
Absolutely, yeah.
And look, why is that the case? It's to save money.
Also-
For the patient, I'll call it out.
No, it is, yeah.
Hospitals get dinged. If a patient is readmitted under a certain time frame,
30
they are
days.
financially, they're in trouble.
Yeah.
They get slapped.
So they
don't
want to
that.
work with skilled nursing facilities who have high star ratings, low readmission rates, so that they're going to be basically preaching the same conversation that they're trying to do in the hospital.
And rightly so, they are penalized because it's not like a random penalty. It's made so they do the best that they can to prevent that, because it's bad for patients, right? Anytime they're in the
Correct.
hospital, they get weaker, they are exposed to dangerous situations. So they get penalized if they go back for a reason that could be prevented.
It is worth acknowledging that it's for the patient's behalf.
It is
It's
for the
not,
patient's
it's not
behalf.
to fatten the hospital.
I'm so glad you
just
said
not
that,
to-
because we're
That-
here
no,
like,
no, well,
there's,
look.
yeah.
We'll talk you guys up. Okay. So again, time flies by. We have Dr. Carlos Zamora. I'm calling you Dr. Z from now on. John Moses, both with Cardiac Vision. That is What the Health Just Happened. All right. Welcome back to the second half of What the Health Just Happened. If you missed the first half, you can catch it next week, someday, on whatever your favorite podcast platform is. I don't know, Apple, Spotify. There's like 800 podcast platforms. John Moses, the Director of Marketing with Cardiac Vision. Dr. Carlos Zamora, board-certified cardiologist with Cardiac Vision. Again, pretty cool organization doing some special stuff in the post-acute world. Talked about an event they have coming up at a symposium October 13th, 2023. We'll talk more about that. A lot of cardiac stuff, a lot of post-acute stuff. We're going to have a little fun before we go back to the serious stuff. So I like to play a game called Healthy or Not Healthy.
All right.
Healthy or Not Healthy. John Moses' shirt size right now.
Oh my God!
I think he needs. I'm messing with you. Come on,
Wow,
man.
it's gonna go.
I would
it's
say
gonna go wide.
sexy. I mean healthy.
Healthy. That is healthy. You're a healthy
right.
man.
That's right, man.
I get
That's
a hard
healthy.
time all
He
the
works
time.
out. He
I work out with
give
Eric.
it
I
up.
don't want to hear his stuff. He's over
I
here
do see
deadlifting.
this guy. I
know.
do see this guy there. Okay.
It takes time and effort to pump it
Healthy
up.
or not healthy, the hours you get to sleep during med school.
Unhealthy.
It is super unhealthy.
It is. Yeah.
Okay. Healthy or unhealthy, wearing scrubs after leaving the hospital.
I would say it depends on what department you work. A lot of people are with scrubs. They are on the desk all day. So
I left when I worked in the ER. I would go home and like immediately just
ER. Yeah, it's unhealthy.
Yeah.
Yeah,
Burn those in
unhealthy.
the car,
You're
yeah.
exposed to all kinds of things.
Okay.
Unhealthy then.
healthy or unhealthy, those clog shoes that nurses wear now.
The
You know what I'm talking
the
about?
Crocs.
They're like not even Crocs. They're like heavy bottom.
Oh yeah.
I think it's
Crocs
unhealthy.
I do too.
I tried it once. It's a rock. I don't know how they do it.
Did you really try it?
Yeah.
Either of you have just a random healthy or unhealthy you can throw off the top of your head? You don't have to. A lot of people are like, I can't.
No.
think of one.
Okay.
It could be
Yes, he has
Elvis.
one.
I hope you
no,
do.
no. Okay, we talked about it earlier. Healthy or unhealthy? Celsius energy drinks.
I'm leaning towards unhealthy, man.
Yeah,
It's a tough one.
Unhealthy. I actually, when I was fresh out of fellowship, I was at Mount Sinai in Miami. We published a paper. A 21-year-old guy that had myocardial infarction, a heart attack, and he had consumed energy drinks. He had done other things too, but there's some ingredients there that are not healthy.
Consistent.
Yeah,
Consistent and exaggerated amount.
Justin Couscous, I call him, by the way.
Yeah.
It's not his last name. How many energy drinks do you have a day?
1 Celsius a day.
Okay. At least, they're going to say.
Yeah, I think it was a large
We'll do an
amount in a short
echocardiogram
period of
when
time, and probably mixed
Too much.
with other drugs.
Yeah.
So
Alcohol, possibly,
exactly. Yeah.
stimulants.
They kind of remind me of like a poor man's version of the Four Locos. You remember the Four Locos?
I think the Four Locos are a poor man's version of
Oh, well, yeah, probably.
like strong. By the way, there's one. Healthy or unhealthy, Four Locos.
Oh,
Unhealthy.
the original recipe.
Do you know
Oh,
what, Dr. Z, do you know what
I
I'm
don't
talking-
know what
You
that
remember
is.
Four Locos?
It is an energy drink combined with alcohol.
the original version, not so
Yeah,
much.
they're,
Wow.
they're banned. The original
Yeah,
version.
you can still get them now. I think they had to nerf the ingredients because they were killing. They were not, well, they were
Yeah,
messing
there we
people
go.
up.
I
There you
told
go.
you we'd go off run. Let's rein it in. Go back to cardiac vision. Okay, did a little bit of healthy or unhealthy. I love doing that. So I have a medical dictionary. This is from nursing school. I like to open it randomly. I'm going to read a term.
All right.
If you don't know what it is, you still have to make up the definition.
Okay.
You in? Let's see here. Let's go early on. We have constipation. That's what I picked, man. I'm sorry.
Go ahead.
You gonna tell me what I think it is?
Yeah.
To go define
Oh,
it.
it's my turn. Oh,
Yeah,
okay. I
go.
thought this is a clinical question.
No,
so,
we're all gonna make it up. Or,
That's
or
an easy
answer.
one.
do I
That's an
know it
easy
or do
one.
I make it
No,
up?
if you
Whatever
know,
you
say
want.
it.
You never knows what constipation is.
you're backed up. Your stool is backed up. That's basically what it is.
There's
You
a
can't,
med-
and you
it's-
can't go.
So in the fire department, we call it FOS, full of sh. Everyone likes an acronym. That was too easy. All right, I'm
That
gonna
was
switch to
easy.
I was
another-
about to
John.
say, come on.
You fix
We're
it.
gonna go to.
Oh, guys, I think it'd be something really bad.
Oh my gosh, the second one's impacted.
Oh my God, man! You
That
got.
can't be real.
Yeah,
This
it
is
can't.
wrong.
Yeah, that's
I got
too
it, I got it.
too
I
I think
much
you
of
did
a
that on purpose.
coincidence.
I feel
Immunotherapy.
Immunotherapy. It's when typically a type of medication or therapy that targets the immune system. I've seen it for big movement on that in cancer treatment.
treatment for sure is a big one.
Apparently, I'm not a hematology oncologist, but from what I understand, there has been great advance on that, targeting some specific type of cancers that as you know, there's many receptors and markers that they can test these days, and there's some very successful drugs that I know of there.
I feel bad. That went longer than I anticipated because the first one was constipated and the second one was impacted. So sometimes we're not that serious on here. Also, the definition for immunotherapy goes like 3 pages because there's all
Wow.
these subsets. But
Yeah.
You
I
want,
think
you sure
guys
you want to
both
read
nailed
that?
it.
You know, we can.
I mean, it will waste the whole show.
Yeah, exactly.
All right, back to cardiac vision specifically. So you guys specialize. This is me simply defining it, right?
Right.
In cardiac care in the post-acute world, right? Cardiac can-
specialty
a
care,
lot of
specialty
things,
care,
specialty
but yeah,
care.
cardiac specialty care.
Let's start with, again, let's emphasize this event you have coming up, the Post-Acute Symposium. It's the 5th year, continue to grow. What kind of speakers are we looking at? What kind of audience? Who should go that maybe doesn't know about it?
Right. So we're so from a speaker standpoint, I tried to it's honestly, it's been me. Like me and a couple of my colleagues been putting it on. So like, but last year was my first opportunity to kind of dive into it because we had the couple COVID years where you didn't want to do a lot of mass, getting people together. They were still kind of exiting out. So last year, and then this year, this has been something that it's kind of like my baby, so to speak. So but honestly, like there's been some fantastic. Our Tampa person, Carly Clem, she's helped out tremendously with the marketing material. Dr. Med giving the inside, Dr. Judy Med giving the inside about, making relationships with some of the speakers. Dr. Zamora as well. There's been a lot of input from a lot of different things. So from the speaker standpoint, so I kind of wanted to make a wide range of, hit different points, different points for our speakers. So you have the two hospitals, St. Vincent's and Baptist will be speaking. That's Sandra Jenkins and Kimberly Lewis. They're both directors of post-acute care or some version of that.
Kimberly Lewis, director of care management, Ascension, Florida, and Gulf Coast.
Exactly.
Who was the other one?
Sandra Jenkins. So she's
Sandra Jenkins. All right, director of post-acute care, Baptist Care Partners.
So they're going to talk a lot. Yeah,
large locations in Florida.
Right.
Talking about a topic that maybe is not discussed enough.
Right.
Continue.
So those two, like we've had them the last few years. They're fantastic presenters. They do a great job, kind of giving their perspective, their hospital's perspective on post-acute and what that looks like for their side, the relationships that they need, and so on and so forth. I'm not going to steal their thunder. You got to come out and see.
Maybe I'll be there.
Yeah, exactly.
I'll be there.
Another one. Yeah, right. I don't believe it. And then so Dr. Tovar will be from H&I. So H&I is they're the hospitals group that rounds in all the St. Vincent's. So they're the actual physician groups that worked for H&I.
Similar one with. Got it.
So like Sound Physician or something like that. So, but they cover all of St. Vincent's, but they also work in about a couple dozen skilled facilities here locally as well. So they understand the acute side, but they also understand the post-acute side. So they're able to give both perspectives of what they're seeing. So Dr. Tovar is their CMO. He's coming in and speaking about that. Next, you have Chris Adams from H2 Health. H2 Health is a outpatient rehab group that does that rent space inside ALFs for Medicare Part B services. They also have outpatient clinics that you have brick and mortar clinics they go to, and they actually go into the private homes too and be able to do Med B services inside the home, which means that they're able to do, once home health is completed, they're able to continue on the therapy once they get discharged in the home.
Did they pay you to promote their business?
They did not. So, and you had a colleague of yours, Mr. Sapia. His wife works for H2.
Oh, that's right. You did mention that.
Yeah. So
they also have signs in the Jumbo Shrimp. You ever go to a Jacksonville Jumbo Shrimp game?
No.
I don't know why I noticed that.
They do. Yeah. So they do.
They're
They're a great organization. Chris is she's their COO, so she'll be coming in and speaking about that. Nice. You also have Stephanie Markuski with Cypress Village, which is a large healthcare entity over there over off JTB. CCRC, exactly. So they have a skilled side, they have an ALF side, and they have an independent living side as well. So Stephanie oversees the entire healthcare administration for the entire property. So she's a perfect example of what we would need to kind of bring in and kind of tie that in from the post-acute because she sees the skilled side and the ALF side and the independent living side too.
What does Cardiac Vision do in an instance like that? So you're starting at skilled nursing, right? Then they downstep to maybe it's assisted living, and then they downstep to independent living. So you're sticking with these patients the whole time.
In each iteration where they go, we would follow them on a property like that. So because it's all one area. So if it's all, have you been there recently? Have you ever
spent a lot of time there 5 or 6 years ago?
Yeah, I was about to say, I've probably been there for a little bit. So it's just, you go on property, it's got multiple homes, high rises, ALF, independent living, great organization. So Stephanie, she's the healthcare administrator there, so she's going to be talking about how post-acute is affected on her side from ALF and from the skilled side. Then we have Melissa Gadd. She's with Concierge Home Care.
Is the Medicare side or the
Medicare.
Side. Okay.
The Medicare side. Yep. So Concierge Care actually is the second largest home health care company in the state now, I believe.
Yeah,
so.
they've exploded since I left that space.
Yeah, so they've exploded. So Melissa's going to come in and talk about her experience from the post-acute, from the home health side too. And of course, Dr. Shaw. Dr. Shaw is with CRT, Cardiorenal Therapeutics. He is our nephrologist. He oversees our nephrology side and also works in the other states as well. So he's going to be talking about more the nephrology, cardiac vision, CRT side, what he's seeing for post-acute. So it's a lot of good information, of course. And then Dr. Z will be there I guess he'll come. And then Dr. Desh Mukesh will be coming in. He does Balance Wellbeing, which is a psych group that comes in and works directly with the post-acute in the skilled setting, and also the ALF. So very similar to us, but they do psych. So they're able to have nurse practitioners who do psych. So they're good partners of ours. They work with
another huge
yeah
necessity in that
absolutely.
world.
And Dr. Desh he's a fantastic speaker. He really does. I don't know if you remember him speaking last year, Dr. Zamora.
Yeah, I've seen
so
it before. Yeah,
he really
conference. Yeah.
He really ties together how, from a psych side and psychological side, how that plays an integral part in the healing process for rehab and for the post-acute. Because if a patient has anxiety or has depression or what have you, it can radically affect their health, and not to mention the potential for rehospitalization.
Mm-hmm.
So if you deal with that from the front end and manage that through their entire post-acute process, just like with cardiology, it's just as important, if not more important, because your brain controls everything else. So
clearly, John is planning this event. You nailed that. Like, you talk through each guest specifically. Like, you could probably talk about what they're going to be wearing.
Yeah, I sent out. They're all going to be wearing What Health Just Happened shirts.
What the hell?
Yeah, exactly.
I'll bring a box of these.
Just remember the cannon. You got to get the gun. The T-shirt
the cannon gun. I would like one of those. Okay, so let me ask. I don't know who would answer this better.
Sure
most of the patients that you're dealing with, are they Medicare population?
Oh, absolutely, yeah.
So 65 and older.
Typical 65 and older, yeah.
How are they referred to Cardiac Vision? So how do you get an intake from a patient, and what's paying for the service? I think some people don't talk about how the money flows in this world. I think we should.
Right.
Is Medicare covering? Like, who wants to take that?
Well, Medicare covers it, and so or their managed care program or whatever insurance they have. We do work with most, if not all, insurances for what we do. So how it works is that in a perfect scenario, a patient comes in. If you have a proactive skilled nursing facility or a proactive assisted living, a new patient comes in, you can look on their 3008, which is like their admitting documentation to a skilled nursing facility, or a 1823, which is their admitting documentation for an ALF. They all have to have these documents, which give their entire healthcare history about where they came from and what their diagnoses are. And if you have a good admissions person or a good marketing moving coordinator.
How many of those are there? The majority? Or
there's more than you think.
Okay,
there's more than you think, but there are opportunities for success for sure in every industry.
Everything,
across the board. But if you have an active building who has who's looking at what you're going to do for that patient from the day they walk in the door, they may refer us right off the bat. It's like, hey, we have a patient coming in. They're moving in on a Monday. Dr. Zamora, when are you rounding? When can you come see this patient? Or maybe one of our nurse practitioners, hey, when are you coming in? I have a new consult for you. And so we see those patients as soon as they move in, because if they move into an ALF or they come admitted to a skilled, the earlier we see them in the skilled, the better. Because because we may only get 3 weeks to see them in that skilled building before they go home or because they ALF or they move out of the country or who knows where they go. So the earlier we get on, the more preventative care and more proactive care we can provide. So same thing with ALF. We get consulted early on in that process.
The sooner you see them, the better their outcomes.
Now, worst case scenario, they usually wait for a primary to come in and do an evaluation, and the primary makes that decision where if they feel like they can manage what they have, or if they want to bring in us or another specialist to help manage that side, like the roofing or the electrician, they want to manage that side. So that leaves a lot to be desired, but there's also, that's why we have good partners in the post-acute space for primary care. So they're like-minded with us, and they see that.
Dr. Z, I like to ask random clinical questions like I mentioned. Also, I say hi to my mom every episode. Hi, Mom, I love you. We were talking on the way to the show today, and this is not medical advice. I have to say this. So her friend, she has a cardiologist that says every human should take a cholesterol medication. Every adult should be taking a low dose of cholesterol medication. Her doctor says no, absolutely not. Again, this is not medical advice. Where do you stand on that? I think no. I'm telling you
who
right
said
now.
yes? Her friend or
her friend's cardiologist is telling her friend that every human should be taking some low dose form of cholesterol medication.
And her cardiologist is saying no.
No, not every human should be taking that.
Yeah. No, I mean, I don't think so.
I don't think so.
No.
So what instances should people start getting on cholesterol medication?
Yeah, it's a good question. there are two things that drive that decision: primary prevention, and secondary prevention, we call it. That's the simplest way to look at it. There's primordial prevention, there's tertiary prevention. But let's say primary, secondary. Primary means you don't have a cardiac event or a cardiac diagnosis. You just have high cholesterol. Secondary means you have an event or a cardiac diagnostics or a cardiac procedure done, like a stent, or you had a heart attack, or you had a stroke, or detected, a large amount of plaque. Those are typically secondary prevention, we call it. The studies are more favorable that they do reduce events there. If you take it, you have to take it for a long period of time. It's a, cardiovascular disease, and specifically atherosclerotic disease, which is what the statins are going to try and help here. And we mentioned the Peter Attia book. I haven't read it, but I have heard him saying, and we say it starts as after you're born.
Yep.
You start building up. Like you're aging, you're already breaking down DNA, and you can start building up plaque as a child. And so it's a spectrum, and it's a slow game, and it depends on how you fluctuate throughout your lifetime, and it's a cumulative effect. So you always hear about a 45-year-old that collapsed and died while jogging or at the gym, right?
I'm 40, man. That's only 5 years away.
Well, but you have heard a story, I'm sure,
Yes,
about that. So what happens there? And they say, they were healthy, he was in shape, he was training for a marathon. What people don't take in consideration is that he's 45, and remember I just mentioned that things start at birth, right? So when in college time, which not him but many other folks just ate whatever junk food they could afford, right?
Count me in for that one.
Yeah,
Guilty.
so
There's some Taco
all
Bell.
of
What you eat
you
in college is
Waffle House, Taco Bell, count me in.
Yeah, I mean, I'm
Trey's
sure.
a college buddy, by the
I'm
way.
sure
You're
you
not
were
eating
not
healthy in
eating salad with organic
No.
and a little bit of vinegar and olive oil straight from Italy. So, unfortunately, most people do that during those 4 years, and that adds up. And depending on how bad you did,
4 years.
4
That
years.
took me like 6 years to graduate
Well,
college. I'm kidding. Sorry.
Well, if you did it for longer, the longer you were exposed to those very atherogenic diet, the worse, because you already started accumulating little plaque. There's microscopic things start sticking to the blood vessel wall, and unfortunately, they don't go away. And so you typically, what happens then at 30-some, had kids or settled down, has a job, is making money. Now, okay, wow, I got to take care of this belly or get in shape. And start training for a marathon and getting in shape, is fit. But that process was already going. Mm-hmm. And then there's an event that happens, like the perfect storm. I always say you don't cook an event out of the blue. It typically requires ingredients, just like when you're cooking. And the different ingredients are high blood pressure, genetics, history of smoking, even if it was remote, history of a bad diet for many years, and we just keep finding out on more and more risk factors, like pollution. That has been proven. So it just takes a perfect storm. Vaping, there are some bad, there's some bad studies about it. But all of those add up. It's not just one thing typically. So when all those add up, that can create that event, but was an event that started years ago. So to answer that question about the debate, if there's plaque or there was an event, certainly after a stroke or a heart attack immediately for the first 90 days has shown that improves their long-term longevity.
If you ever get the itch to come back, I'm telling you, I would talk cardiac stuff all day just because I think we can make it fun too, but we'll go back to cardiac vision.
Yeah.
So the majority, I would say 100% of the patients you're working with, 65 and older.
The majority, yeah.
I would say majority. We do get some that are, some like early in life.
How many of them are dealing with cardiovascular disease?
Yeah, I mean, 100%? Almost 100%. The ones that we see are 100%. And in that building, the large amount, right? The large percentage of them have, like I said at the beginning, those diagnoses, at least one of them, might not have been in the hospital for an acute problem related to that diagnosis, but those diagnoses are there. They interact with medications that they're taking. They're taking multiple of them, and so it's the great population that we see, and that it continues to evolve as we have baby boomers every day,
10,000
a day.
States.
So they're the ones that are moving to those CRC CCRC communities, continuing care communities. So they start independent and going to the other
That's a good segue because I think we got about 4 minutes left here. Good question for you both to wrap up. So you mentioned owning an assisted living facility.
Yeah.
Unfortunately, we can't talk about that. What's it called? Just at least say that.
Better Days Senior Living.
Better Day Senior Living. So it's just a good question. If you look at your space specifically, let's call it the post-acute world. Mm-hmm. What's one healthy change you'd like to see in that industry that you think would improve the post-acute world?
I mean, don't ask me this. We don't have enough time to talk about it.
Well, you got 3 minutes,
so hurry it up. Let me
see
the timer. Let me set my timer on my new phone. For me, I think that, I think things like I know this sounds kind of like I'm self-chanting here, but things like we're doing with the symposium, it's really drawing attention. That's easy first step stuff that we can do to draw attention to things that people aren't talking about or don't know there's a problem. Mm-hmm. A lot of times these people get the acute, the hospitals or the acute or the skilled nursing or what have you, they get a patient come across it as like, oh, this person's going home. Let me write that up and just fax it over and just hope they get taken care of. Like there needs to be more. Some spaces do a great job, some don't. So it's about figuring that out and stop. You guys mentioned earlier the silo effect. Like let's stop the silo.
Communication,
exactly.
Collaboration.
And it's at the end of the day, I really feel, and this is something I'm very passionate about, and I'll let Dr. Zamora go because I could talk for hours, and you guys won't hear my voice that often. But I really feel that a lot of our post-acute partners, a lot of our people, a lot of our partners need to think more about how they can be a resource for that patient, not just for what they can do, but what else can they bring to the table for that patient.
Not just treat and see you later.
Like not tunnel vision.
Yeah.
If you're home health, if you're private duty, if you're skilled, if whatever it may be, you're just saying, I'm going to stay in my lane and that's it. This is healthcare, not self-care. You're not worried about yourself. Like you should be worrying about that patient. At the end of the day, healthcare is about taking care of that patient. It's putting your needs aside and getting that person as much health as possible, much care as possible. And the only way to do that is to think about what else that person needs. And even if it doesn't, if you don't know they may need more, educate yourself. So, or, go to these things and talk to these people. Anyway, I'm done.
I like that. Anything you want to add, Dr. Z?
I think he covered it all.
No, there's no way.
Job.
There's no way. What would you change? There's got to be something, Dr. Zamora. What would you change?
I think, go ahead.
I'm good with your answers. It's great.
Collaboration,
continuity, care.
Creating awareness, like you said, too, which again, the symposium, October 19th from 9 to 3 at 13th, excuse me.
Friday the 13th.
Friday the 13th. I'm definitely not going. Okay.
Well, you were already wearing black, so you'll be scary already. So,
again, here we are out of time. There's so many different things to talk about. Hopefully you guys want to come back, but either way, I appreciate you coming on. It was great. Cardiac Vision is doing some pretty incredible stuff here in Northeast Florida, across the state, now moving into other states as well. John Moses, Regional Director of Marketing, Dr. Carlos Zamora, a cardiologist with Cardiac Vision and UF Health and some other places as well, owns an assisted living facility with his wife. We didn't even talk about that.
Yeah, next time.
Gentlemen, thanks for joining. Like I said, I had fun. Hope you guys did too.
Yeah, we did.
Thank you. It was fun. Thank you for having us.
That is What the Health Just Happened.